Distinguished ladies and gentlemen, a warm welcome to all the remarkable women in our midst as we are celebrating the International Women's Day today, recognizing their valuable contributions alongside the steadfast support of the men among us. I firmly believe that this day is not solely for the acknowledgement of the woman, but for every gentleman present who upholds the respect and kindness towards men. My heartfelt wishes for International Women's Day extend to each and every one of you. A woman encompasses numerous roles, and among them, the profound role of motherhood, a sentiment cherished deeply within each of our hearts. In the context of our professional domain, KPGA stands as one of the pioneers for the pharmacy graduates in the state, fostering a sense of maternal care and intimacy and the connection. Today, we are so much privileged to partake in another enlightening session organized by KPGA on the topic Clot Management and Prevention Journey Through Anticoagulants. It's with immense gratitude I, Sonu Beni, PhD research scholar from Amrita School of Pharmacy, assume the role of host of this event. On behalf of KPGA, I extend a heartfelt and enthusiastic welcome to each and every one of you joining us for this national webinar. Welcome, everyone. I'm kindly requesting all the participants to keep your audio muted for the smooth functioning of our webinar. To begin our event on a harmonious note, let's welcome Ms. Adira RS, faculty at Pharmatech Hyderabad, as she graces us with her melodious voice for the opening with a prayer song. Welcome, ma'am.
Thank you, ma'am. നന്മയാകുന്ന കാന്തി കാണുവാൻ കണ്ണിനാകേണമേ, നല്ല വാക്കിൻ്റെ ശീലു ചൊല്ലുവാൻ നാവിനാകേണമേ, സ്നേഹമാകുന്ന ഗീതമോ എൻ്റെ കാതിനിടയാകണേ, സത്യമെന്നുള്ള ശീലമോടെ ഞാൻ ശാന്തി അറിയണമേ. ഭൂമിയമ്മയെന്നറിയുവാനുള്ള ബോധമുണ്ടാക്കണേ, ജീവജാലങ്ങളാകെയും ജന്മബന്ധുവായിടണേ, ജാതിഭേദങ്ങളെന്ന ശാപമോ ദൂരെ മറയണമേ, ലോകമെന്നൊന്ന പാഠമെന്നുമെൻ മനസ്സിലെഴുതേണമേ.
Thank you so much, ma'am. It gives me immense pleasure to welcome Mr. Abdul Nasir PU, the dynamic General Secretary of KPGA, for welcome the gathering. With much happiness, I invite you, sir.
Thank you, Sonu. A warm good evening to one and all, and wishing you all a happy World Women's Day. Respected President of KPGA, Dr. Srikumar Sir, dignitaries, KPGA members, members of other associations, our seniors members, and my dear participants. It gives me immense pleasure to be here and to welcome this program. Kerala Pharmacy Graduates Association is one of the oldest professional association in the state, working for the upliftment of the pharmacy professionals in Kerala. KPJ is dedicated in serving the needs and interest of the pharma professionals. From time to time, KPGA strongly made intervention in the problems of pharmacy professional, not only in the state but also nationwide. The activities of KPGA is extended throughout the professional sector. The notable events are the KPGA conduct the Kerala Pharmaceutical Congress. It is one of the event that was organized by KPGA as a state level meeting in our country. Furthermore, KPGA is doing lot of webinar, seminar, symposiums, conferences, workshops, etc. Kerala Pharmacy Graduates Association is having a strong organizational structure. We have got our KPGA general body, then we have got our executive committee. We have the subcommittees of KPGA Women's Wing, KPGA Students Wing, and NRI Forum. KPGA Women's Wing is doing a very wonderful work under the leadership of Kala Madam. Also, we have got a official publication Farmlight, and we are having the 3 edition of Farmline in a year under the eminent leadership of the chief editor of Farmline, Dr. Bobby Jones. So I would like to request all of your support in the future programs and the activities of KPGA. Now I would like to move to my responsibility. First of all, I am welcoming Dr. Srikumar sir. We KPGA would conduct a lot of activities and programs under the eminent leadership of Srikumar sir. I wholeheartedly welcome sir to this webinar. Next, I would like to welcome today's resource person, Dr. Vikas PV. I welcome Dr. Vikas, and also I especially thank him for accepting our invitation and to participate in today's webinar on the very important topic, clot management. I welcome Dr. Vikas to this program. Next, I would like to welcome Mr. Rajesh Thalambarapat, the program coordinator and the moderator of today's program. I welcome Mr. Rajesh to this program. Next, I would like to welcome Dr. Sinu Thomas, the chair of today's program. I welcome Dr. Sinu to this program. Next, I would like to welcome Dr. Sujit Verma, Principal at Thachan College of Pharmacy, and Dr. Ansa Philip, Principal, Father Joseph Marthama College of Pharmacy, Dr. Nishit MC, Drug Inspector Malappuram, and also I would like to welcome Dr. David Paul, Assistant Professor, Naipur, Calcutta. Also, I would like to extend my welcome to Sonu Benny, the Master of Ceremony of today's program. Also, I would like to welcome Adira, who made a very melodious prayer song in today's webinar. Finally, I welcome all the audience and all the members of KPGA and other association, our senior members all, very wholeheartedly welcome one and all. Thank you so much. Yes, Sonu.
Yes, thank you so much, sir. Thank you so much for giving a great opening to our national webinar. Next, we are much honored to welcome Dr. P.K. Srikumar, the president of KPGA, who will share his vision and insight with us through his presidential address. With much happiness, let's welcome Srikumar sir for the presidential address. Welcome, sir.
Thank you, Sonu, for your kind words. Very happy Women's Day to all. Good evening and good evening to all. Then the Secretary, Sri Abdul Nasir, the resource person of today's event, Dr. Vikas Devi, then Mr. Rajesh Talaparambat, the moderator, the executive member, and program coordinator of this function, Dr. Sinu, who chairs the session, and Dr. Nishit, Dr. Ansa Philip, then the executive members, our David Paul, Srimati Atira, and Ms. Sonu Benny, and dignitaries and their professionals and fellow pharmacists and budding participants. First of all, I thank Sri Rajesh Talaparambatta, who arranged this programs, utilizing the service of a great personality, Dr. Vikas, who will share his vast knowledge in the subject for all of us, especially those who are in the clinical side, say PharmD and PharmD practice sector. KPGA is arranging a lot of programs for the last many years with a view to enrich our future generation with power-packed knowledge, I should say, in their respective field. So we are conducting a lot of seminars, webinars, big conferences like Kerala Pharmaceutical Conferences, activities on industry, like activities to set up Pharmacity. Then career opportunity related series of webinars, student funding, competitions for students, community outreach programs by especially our women's wing, then programs on drug awareness or AMR, etc., etc. A lot of programs. So the importance of clinical pharmacy in clot management and prevention cannot be overstated. Through comprehensive medication management, risk management, patient education, and the close monitoring, clinical pharmacists significantly contribute to reducing the incidence of the events such as thrombotic events, then improving patient outcomes and enhancing the quality of care for the patients with or a risk for clot-related conditions. Then clinical pharmacists are uniquely positioned to contribute to the care of the patients at risk for or suffering from thrombotic events through various means. That means the subject for the webinar is having much importance in the present scenario, and the experts in the field will definitely make the event colorful and most useful. I would like to request all the participants to support the association and executive, the committee, to materialize the great projects. We are working with strong and focused vision and mission. You are now a part of the honorable tradition of healthcare professionals who have dedicated their lives to the betterment of society, and let this type of well-designed and organized programs find a result to empower pharmacists to do more, build up our next generation pharmacists, and thus future pharmacists and experienced pharmacists will definitely shine on that. Thanking you once again, and wish all participants and the team all the best, and wishing the programs to be a great success. Thank you.
Thank you so much, sir, for your wonderful words and for your very wonderful leadership that you are giving to us always. Now, with immense pleasure, I would like to welcome Professor Dr. Ansa Philip, Principal, Dr. Joseph Marthoma, Institute of Pharmaceutical Sciences and Research, Katanam, as she shares her felicitation and enriches our event with her presence. Heartfelt welcome to you, ma'am, for the felicitation.
Thank you, Sonu. Respected dignitaries of KPGA and all my friends, good evening to everyone. I am honored to be a part of this online webinar of KPGA community of commemorating the Women's Day and tribute to the association unending pursuit of excellence through continuing pharmacy education. The topic chosen for this webinar is clot management and prevention, journey through anticoagulants, is also highly relevant for the pharmacists today due to the increasing number of emergencies that result in the usage of life-saving medicines. I take this opportunity to appreciate the speakers and congratulate KPGA and its leaders for once again showing your vision and commitment in building this profession and raising its standards. Let us join hands with the organization in building a vibrant pharmacy community in Kerala. My best wishes for the program and success. Thank you.
Thank you so much, ma'am. Next, I would like to extend a warm welcome to the very dynamic member of our profession, Dr. Nishit MC, Drugs Inspector from the Drugs Control Department, Malappuram, a strong member of all our association as he honors us with his felicitations. A warm welcome to you, sir.
Thank you, Sonu. Respected Secretary and President of KPGA, today's resource person, Dr. Vigas, other distinguished guests and participants. I'm so happy to join with you all today on this virtual platform to facilitate this function. Even though I'm also a part of KPGA, I take this opportunity to congratulate the entire team of KPGA for regularly organizing seminars like this for updating the knowledge of pharma professionals. Today's topic is also very relevant, especially the professionals working in clinical side. I hope the resource person can give detailed insight and updated information on this topic. Wish you all the success for this program. Thank you.
Thank you so much, sir. Now, we are moving to the heart of today's discussion. The fascinating, we are moving to a scientific session on the topic clot management and prevention, journey through anticoagulants. Leading this session, we have Dr. Sinu Thomas, Professor and Vice Principal of Caritas College of Pharmacy, Kottayam, as the chair. And to be brief about the chair of the session, Dr. Sinu Thomas A. She's an alumnus of Oxford College of Pharmacy, Bangalore, and JSS College of Pharmacy, as she has done her BPharm and MPharm from these prestigious institutes. She had completed her PhD in Pharmaceutical Sciences from Manipal College of Pharmacy, followed by an MPA in Pharmaceutical Management. She started her career as Vice Principal at AM College of Pharmacy and Caritas College of Pharmacy till 2004, and later she joined the Department of Pharmaceutical Sciences, Mahatma Gandhi University, Kottayam, as the faculty member till 2020. She has guided several PG students and now supervising her PhD scholars. She has authored a number of articles in various prestigious journals of national and international reputation and served as a resource person for several conferences. Her current area of research interest is small molecule synthesis, computer-aided drug designing, and spectral interpretation. So with much happiness and respect, let's invite Sinu ma'am to chair the session and to introduce the moderator. Welcome, ma'am.
Thank you, Sonu. Good evening, ladies and gentlemen. We gathered here to be a part of this scientific session on clot management and prevention, focusing on the journey through anticoagulants. As we all know, clot management and prevention are critical aspects of healthcare as they play a crucial role in preventing life-threatening conditions such as strokes, heart attacks, and pulmonary embolisms. Anticoagulants are vital in this process as they help to prevent the formation of blood clots and reduce the risk of these serious complications. So today, we will hunt into the latest developments and challenges in the field of anticoagulation therapy. Throughout this session, we will have the opportunity to hear from experts in the field like Dr. Vigas PV, who will share his insights and experiences. So together, we will explore the evolving landscape of anticoagulation therapy and its impact on patient care. I encourage you all to actively participate in the discussion, share your thoughts and experiences, and together we can enhance our understanding of clot management and prevention. It's my pleasure to welcome our moderator, Mr. Rajesh Talaparambat, a seasoned professional in pharmacy operations and who has a rich background spanning clinical, non-clinical, and administrative roles. With B.Pharm and M.Pharm degree from Ramakrishna Institute of Paramedical Sciences, Coimbatore in 1998, he started his career as a lecturer at JSS College of Pharmacy, Mysore. His career took him to Saudi Aramco Medical Services Organization, now known as Johns Hopkins Aramco Healthcare, where he held various roles culminating in manager of inpatient medication management services. Throughout his tenure, he was involved in pharmacy automation and informatics systems, contributing to patient safety initiatives and participating in several committees that reviewed various clinical pathways, including those for COVID-19. In addition to his operational roles, Rajesh has been actively engaged in education and professional development, serving as a preceptor in hospital pharmacy and internal medicine, training pharmacy students, residents, interns, and summer students across Saudi Arabia. He has presented at numerous conferences, including Indian Pharmaceutical Congress, and has been an invited speaker at events like the Arab Health Conference in Dubai. Since February 2023, Mr. Rajesh has been serving as the Senior Manager of Pharmacy Operations at Mitra Hospital, Calicut, furthering his contributions to the field of pharmacy. I wholeheartedly welcome Mr. Rajesh for moderating this session.
Thank you so much, Dr. Sinu Thomas, for this wonderful introduction. Thank you so much. It's my pleasure to introduce Dr. Vigas, who is my colleague now. Dr. Vigas is Assistant Manager of Clinical Pharmacy at Mitra Hospital, Calicut. And throughout his dynamic career, he got extensive experience as a clinical pharmacist across various critical and non-critical departments, including cardiology, cardiovascular, thoracic surgery, neurosurgery, orthopedics, and rheumatology. Dr. Vigas has been instrumental in shaping the next generation pharmacists, serving as a mentor to clinical pharmacy interns holding pivotal roles such as anticoagulation clinical pharmacist, heart failure clinical pharmacist, and clinical pharmacy consultant. An accomplished researcher, Dr. Vigas has made significant contributions to the field of pharmacy, with his work being published in both national and international journals. He has also presented papers in numerous pharmaceutical conferences, highlighting his commitment to advancing pharmacy practice across India and the rest of the world. Moreover, he is a respected speaker engaging with the pharmacists, nurses, physicians, and public on topics related to the cutting-edge pharmacy education, demonstrating his dedication to the pharmacy profession. Dr. Vikas began his illustrious career as a clinical pharmacist at Aster Med City, Cochin in late 2070s. Where his exceptional skills and dedication quickly led to his promotion to a senior clinical pharmacist. He's an alumnus of Crescent College of Pharmacy, Kannur University, where he completed his bachelor's degree in pharmacy, and Al Shifa College of Pharmacy under the Kerala University of Health Sciences, where he's earned his PharmD program. Dr. Vigas' journey reflects a passionate, committed clinical pharmacy profession, educationalist, and the researcher, making him as a distinguished figure in the healthcare community. So please, Dr. Vigas. So now it's your turn. So can you share your screen, Dr. Vigas, now?
Sure, sir. Sir, can you see the slides?
Yes, yes.
Okay.
Please carry on.
Good evening, everyone. First of all, I am taking this opportunity to thank Rajesh sir, KPGA President and Secretary, and the other dignitaries and the delegates. They are gathered here for the today's session. And I am thanking the KPGA Association for providing this opportunity to present a session on clot management and prevention journey through anticoagulants. There is no additional introduction is necessary from my side, I think, since Rajesh sir is already gave the details about me. So I am straight away moving to the session. As you know, anticoagulants are one of the high alert medication. And these high alert medications are always observed by the national and international accreditation standards such as NIBH as well as Joint Commission International, JCI. Why these anticoagulant medications are become high alert? Since they have very narrow therapeutic index. It means very drop in concentration in the blood may lead to subtherapeutic level, and in very mild concentration hike may lead to toxic level. So always a close monitoring is necessary when dealing with anticoagulant medications. Not only the anticoagulant medication is significant, but also the indications such as these thromboembolic disorders are very crucial when dealing with this medication management. One of the global study done by American Heart Association, and they published in their paper Circulation regarding the incidence of these thromboembolic disorders. And the incidence of these disorders ranges from 50 to 1,500 patients per 100,000 population. When we discussing the same scenario in our Indian population, there are almost similar or parallel incidents are occurring in our Indian population also. The graph showing the study conducted by Ministry of Health and Welfare Association of our state, our country. And the second graph showing that series 2, that brown colored pyramid showing that the prophylactic therapy in our country recommended for the patients. When comparing the global standard versus our Indian standard, the prophylactic therapy is not till reaching the 50% of the population, since majority of our patients are at a very high risk of thrombus formation. So today's topic, anticoagulation management, is very relevant for every delegates. They are gathered here, such as clinical pharmacists, and the teaching professionals. So in order to make this discussion more easy, I have divided this session into different case scenarios. So every case scenario is discussed here, and the related topic also discussed under each case scenarios. So moving to the session, and today's knowledge aspects include thrombotic disease and its prevalence, prophylaxis of thrombotic diseases, and treatment strategies of thrombotic disease, pharmacokinetic aspects of the treatment, and finally drug toxicities treatment. So we are moving to the first case scenario. Here is a patient, NT. It's a 68-year-old woman with height 63 inch and weight 58 kilogram, who presented to the hospital with a tachycardia and diagnosed by clinician or the cardiologist as non-valvular atrial fibrillation. In the short form, we can name it as NVAF. After her heart rate is controlled with administration of metoprolol, the patient is asymptomatic. She also have the past medical history of hypertension, type 2 diabetes mellitus, osteoarthritis, and depression. Her current medications include metoprolol, lisinopril, acetaminophen, and metformin, and finally citalopram. Her heart rate is controlled to 82 beats per minute, and blood pressure is 130 by 80 mm mercury. Her serum creatinine is 0.8 mg per deciliter, and creatinine clearance found as 60 ml per minute. She has a normal hepatic function. And the question related to this case scenario is, which depicts NT's charge to VASC and Haskell score? I think you all are familiar with this charge to and VASC score. So what will be the scoring system, whether it is 2:1 or 4:2, 5:4 or 4:1? I'll be moved to the answer. The answer is charge to VASC score of 4 and Haskell score of 2. I will explain the score system in the following slides. Okay. The patient disease is diagnosed as atrial fibrillation, that is non-valvular atrial fibrillation. The graph showing is the European Society of Cardiology prevalence study conducted in 2020, and the atrial fibrillation population is deviated in around the globe, and the majority of populations are in the European territory, and our country India is ranging from 600 to 699 patients per 100,000 population. Then why this charge to VASC score is identified? Then what do you mean by this charge to VASC score? As you know, the atrial fibrillation is a irregular heart rhythm disorder. During the atrial fibrillation period, the heart will fibrillate or shake in vigorous and irregularly. During the period, a stasis of blood occur in certain portion of the heart that may lead to the formation of clot. Finally, this clot will move to any other region such as brain, and that leads to ischemic stroke or heart, then pulmonary embolism or DVT can also be happen. So in order to find out the patient is what risk is measured by this charge to VASC score, and the charge to VASC is the abbreviation for C for congestive heart failure, and the points has 1, then hypertension, then age has 2 score, the age more than 75-year-old, then age is 65 to 74 year, either score is 1, and the diabetes mellitus 1 score, stroke 2, and vascular disease also 1. And for the female sex category, there is additional 1 risk score is there, then 1 is the score, and the total score is 9. When interpreting the result for the men who have score of more than or equal to 2 is definitely required anticoagulation therapy, and in case of female, the score with more than or equal to 3 required anticoagulation therapy. Based on the disease condition, we can consider anticoagulation for the men with 1 score as well as 2 with the women. So the charge to VASC score is used to find out the coagulation requirement of the patient who is in non-valvular atrial fibrillation. Okay. Then moving to the next slide, Haskell score. Haskell score is to identify the bleeding risk of the patient. So for an atrial fibrillation patient, we are starting an anticoagulant medication. So when we are before starting, we have to know at what risk is the patient right now regarding the bleeding. So this Haskell score stands for hypertension, that is uncontrolled. It's more than 160 mmHg. The point share is 1. And if any abnormality in the renal or hepatic dysfunction, and history of stroke, bleeding tendency, and patient has any INR deviation, labile INR, and the patient age is more than 65, got 1 point, and the intake of alcohol or any other drug such as antiplatelet or alcohol intake, that scores 2. So based on this score, we can assess at what risk is the patient for bleeding. Okay. By knowing this, we can adjust the dose of the medication very crucially. For increased bleeding risk patient, we titrate the medications only stringently. Okay. In other case, we can increase the dose without risking the patient. Okay, I think you understood the Charles-Tooth and Haspel score. We are moving to the next area. There is a new bleeding risk assessment score is there, since this Haspel score is actually developed for the bleeding risk assessment when we are starting with vitamin K dependent oral anticoagulants. The direct oral anticoagulants as DOAC is introduced around 5 or 10 years back. So a new bleeding risk assessment is in the pipeline. This risk assessment score is not yet published in the international guidelines. They are still in the research field. So this direct oral anticoagulant score is recommended to assess when before starting any newer oral anticoagulant such as apixaban, rivaroxaban, dabigatran, and edoxaban. And these are the clinical risk prediction factors such as age, creatinine, body weight, stroke, DM, hypertension, and medications use. Then any bleeding history, liver disorders. Okay, and this score is ranging from 0 to 10, and 0 to 3 for very low risk, and 4 to 5 at low risk, and in case of moderate risk, 6 to 7 is a score, and finally 3 to 7.7 is the very high bleeding, major bleeding risk range. So the next question, what is the most appropriate stroke prevention strategy for NT? Whether it is apixaban 325 mg once daily oral, or rivaroxaban 20 mg once daily oral, then apixaban 2.5 mg twice daily oral, or edoxaban 30 mg once daily oral. So what will be the answer for this question? Except the first one, that is aspirin, that's the antiplatelet therapy, and the next three options are newer oral anticoagulants. So whether these agents can be able to administer for the patient, we can check. So the answer is rivaroxaban 20 mg once daily. So you can realize what will be the answer in the following slides. For the non-valvular atrial fibrillation, the recommended agents are direct oral anticoagulants. As I mentioned, the treatment options are dabigatran, rivaroxaban, apixaban, and edoxaban. The dabigatran is the initially introduced direct oral anticoagulants, and its mechanism of action is direct factor 2 inhibitors. And in case of this rivaroxaban, apixaban, edoxaban, these three agents have a grade X in their category. So their mechanism of action is to inhibit factor 10. So their standard dosing include 150 mg twice daily for dabigatran, and their adjusted dose is 110 mg twice daily, and they are advised to reduce the dose to 110 mg twice daily in case of age more than 80 years, then any drug interaction with verapamil or any other agents, and increased bleeding risk. And in case of rivaroxaban, 20 mg once daily is the dose, and advised to reduce the dose when the creatinine clearance is 15 to 49 ml per minute. In case of apixaban, 5 mg twice daily with a reduced dose is 2.5 mg in case when the patient have any two of three criteria, whether the patient having age more than or equal to 80, or the weight less than or equal to 20, and the serum creatinine is more than or equal to 1.5. And finally, edoxaban. Edoxaban is not that much available in our market, but still they are using in the outside countries, and that medicine is highly subjected to creatinine clearance. Its dose is 60 mg once daily, and the reduced dose is 30 mg. Based on the body weight as well as creatinine clearance, advised to reduce the dose or advised to discontinue if the patient is renal disease. When moving to the pharmacokinetics, these agents are mainly metabolized by CYP3A4, and they are substrate for para-glycoprotein. And in case of liver damaged patients, when patient having childbirth score A, These all newer oral anticoagulants are recommended. There is no dosage administration is recommended, but when the patient having childbirth score B, a caution is advised for dabigatran and edoxaban, but for rivaroxaban can be easily used. And in case of childbirth score C, the manufacturers as well as the international guidelines advise to avoid the use these agents in these childbirth C conditions. Then moving into the next slide, the drug interaction of direct oral anticoagulants. As a clinical pharmacist, I have always stringently identified the drug interactions with the direct oral anticoagulants, because these direct oral anticoagulants effect we cannot be able to monitor. We can administer the patient as per the patient condition with the recommended dosing, but we cannot be able to monitor exactly because the monitoring parameters is available. Actually, factor 10A monitoring is available, but in our hospitals, like in our country, this monitoring is not usually happening because of the cost as well as availability of the reagents. So in case of when we are prescribing or when our doctor is prescribing oral anticoagulants, we have to crucially check the drug interaction with available resources. If the patient prescribed with any strong inducers such as rifampicin or phenytoin carbamazepine or any chemotherapeutic agents like apalutamide, or if the patient have any herbal therapy with the Stephen John wort, or in case of patient have any strong inhibitors such as antifungals, ketoconazole, voriconazole, itraconazole, or antivirals, itranavir, ritonavir, and other antibiotics such as clarithromycin. Similarly, the patient have a strong paraglycoprotein substrate such as ritonavir or ketoconazole or verapamil. The guideline is recommended to modify the therapy. Okay, even if the creatinine clearance recommendation is also considered, we cannot able to monitor the effect of the medication. So when these drugs are in combination with any other these strong CYP3A4 or paraglycoprotein substrate available, the guideline is recommended to change to another available anticoagulants. Okay. In the previous slide, I have missed one agent in this pharmacokinetics of DOACs. There is vitamin K dependent oral anticoagulant warfarin is there. Why this medication was not there in this answer? I purposefully removed the answer from the question because non-valvular AF, the direct oral anticoagulants is the recommended agent. There is an atrial fibrillation. The patient with a valvular disease also. Valvular disease such as rheumatic mitral stenosis or mitral stenosis of moderate or greater severity. These atrial fibrillations are termed as valvular AF. In this valvular AF, the direct oral anticoagulants are not recommended. So in these patients, only vitamin K dependent oral anticoagulant warfarin is only recommended. Okay. Then this is one of the treatment of atrial fibrillation, left atrial appendage closure. The left atrial appendage is an area of the left atrium. There is a chance of clogging of blood in this area. So surgically or as a percutaneous intervention, the clinician or the surgeons can able to close this appendage, thereby this clot formation can be prevented. Even if this procedure is over, the guidelines is recommended to continue the anticoagulation therapy, or in case of a bleeding risk patient, advised to reduce the therapy to antiplatelet agents. So even if the left appendage closure is also over, the clinicians, the guideline is recommended to continue the anticoagulation therapy. So we are finished with the first case scenario of atrial fibrillation and their treatment and their follow-up prophylaxis. So we are moving to the next case scenario. Here is also a second woman with a 51-year-old patient with an height of 65 inches, weight 98 kg, and body mass index 36, who presented to the emergency department with pain, swelling, and redness in her right leg up to her thigh. She also has some shortness of breath and pain in the middle of her chest. She reports she had a history of hysterectomy about 2 weeks ago, and she is not moving from the bed for past 2 weeks. On physical examination, the doctor found that the right leg is warmer than the left and tender to touch. Her cardiac examination appears normal with vital signs of heart rate is 80 beats per minute, blood pressure 146 per 96 mm mercury, and respiratory rate is controlled with 20 beats per minute. Oxygen saturation is 92 on room air. Her initial laboratory information include positive D-dimer and negative troponin, and her creatinine clearance is 65 ml per minute. Based on the patient condition, doctors ordered duplex ultrasonography and found that there is a right femoral popliteal vein thrombosis. And a computed tomography scan reveals a pulmonary embolism. Her other conditions include hypertension, diabetes mellitus, dyslipidemia. She also reports that she has been smoking 1 packet per day of cigarettes for past 30 years, and her current medications include lisinopril, clothalidone, metformin, pravastatin, and hydrocodone or acetaminophen every 6 hours oral in case of pain. So we are moving to the question, which is the most appropriate treatment strategy for MR? The options are enoxaparin 100 mg subcutaneously every 12th hourly along with the dabigatran, and advised to enoxaparin can be discontinued after 5 days. Then second option, rivaroxaban 15 mg twice daily, oral for 7 days, followed by 20 mg once daily. Then enoxaparin 100 mg every 12th hourly for 5 days. Then initiate edoxaban 60 mg once daily. Then third option is unfractionated heparin 4000 units bolus, followed by 1000 units per hour, and warfarin 7.5 mg to an international ratio 2 to 3. Discontinuation unfractionated heparin when the therapeutic INR is reached. The answer is enoxaparin 100 mg every 12 hours for 5 days, then initiate edoxaban 60 mg once daily. When a patient admitted with pulmonary embolism or DVT, we have to go through the patient past medical history, past medication history, and this risk factors. That is divided into 3: strong risk factors, weak risk factors, and moderate risk factors. You can find this Rogers et al. Risk assessment of pulmonary embolism and DVT. By knowing this risk factor, we are re-educating the patient in order to modify this risk factor in order to reduce the recurrence of DVT or pulmonary embolism. So, based on the current clinical patient condition, patient have pulmonary embolism as well as deep vein thrombosis. Based on the patient clinical status, the patient is hemodynamically stable because her cardiac condition is normal, BP, heart rate, everything is normal, and there is no renal modification. Sorry, renal system is affected by this pulmonary embolism of deep vein thrombosis. Okay. In case this patient have hemodynamic instability, okay, the treatment option is thrombolytics. Initially, we have to thrombolyze the patient, and after that, we have to initiate the anticoagulation therapy. So, initially, these are the treatment options for thrombolytic agents. I'm not going to detail these agents since the patient is hemodynamically stable. Then the next option is parenteral anticoagulation therapy. Okay. The parenteral anticoagulation therapy, the first option is unfractionated heparin. If the patient have a increased thrombotic load, heparin administration is recommended as heparin infusion. Okay, so heparin administration in the treatment of deep vein thrombosis or pulmonary embolism is recommended as continuous infusion. Initially, 80 units per kg loading dose followed by 18 units per kg per hour is the recommended dose of heparin infusion. So when we are starting heparin infusion, either for this pulmonary embolism DVT or in case of acute coronary syndrome, we have to monitor the hepatic infusion properly by testing the APTT, means by activated partial thromboplastin time. So this APTT should be monitored every 6 hours for dose adjustment. Initially, we monitor the APTT as a baseline. Then after 6 hours, we monitor again. And if the value is less than 40, that's APTT value is less than 40, that's in the right side column. If it is less than 40, we have to repeat the dose, or we can give a reduced dose by 25 units per kg, and we have to increase the dose. Then again, we have to repeat after 6 hours. If the value is around 40 to 49, and we have to increase the dose again to 2 units per kg per hour. Once we get the value 65 to 85, or mentioned here as 70 to 110, this is the international level. So in the Indian scenario, we usually recommended to follow 65 to 85 unit range. In that, we can stop the APTT monitoring and we can check the APTT value in the next day morning. When we checking the medications, sorry, APTT value, if we get the value more than 85, means 85 to 95, we have to reduce the dose by 2 units per kg. And if the APTT value is more than 100 or 105, or if the blood results shows a not clot detected, at that time we have to stop the infusion for half an hour or 1 hour based on the range, and we can repeat the infusion by reducing the dose by 3 units per kg per hour or 2 units per kg per hour. So this should be continued up to 48 hours, and then we can change it to other oral agents. And if the patient is such moderate risk or moderate symptoms, we can send the patient, or moderate or minor symptoms, we can send the patient to the home with oral anticoagulants. Before that, other options for parenteral anticoagulants are enoxaparin, fondaparinux, and the other 3 agents we are not usually in the hospital settings. The enoxaparin dosing is 1 mg per kg every 12th hourly, or 1.5 mg per kg once daily. Or in case of patient with a 60 kg weight, we can give 60 mg twice daily of enoxaparin. And in case of fondaparinux, 5 mg for patients with less than 50 kg, 10.5 mg for 100 kg, and 10 mg for patient with more than 100 kg. When we are moving to the oral agents, the options are dabigatran, rivaroxaban, apixaban, and edoxaban. For the dabigatran and edoxaban, the guideline recommended to give an initial parenteral dose followed by oral therapy after 5 days of the treatment. And in case of rivaroxaban and apixaban, recommended to give a oral loading dose. In case of rivaroxaban, 15 mg twice daily for 3 weeks, followed by 20 mg once daily. And in case of apixaban, it's 10 mg twice daily for 7 days, followed by 5 mg twice daily. Then the continuation of this anticoagulation for pulmonary embolism as well as DVT. If the patient has not any other risk factors or any unidentified risk, without any unidentified risk factors, we can recommend this therapy for 3 months. And if any risk factor is unidentifiable, we have to continue this medication lifelong, or until if any other risk factors can be identifiable. And patients with this 3-month duration can be extended in case of patient having any other indication for anticoagulation. And if the patient have any Apla syndrome, and in case of no oral anticoagulants, when we are giving no oral anticoagulants, we can able to decrease the dose after 6 months to apixaban to 2.5 mg and to rivaroxaban by 10 mg. Then moving to the next slide. Duration of anticoagulation, pulmonary embolism, and cancer. If the patient have cancer, the first line agent is recommended is low molecular weight heparin for 6 months over vitamin K oral anticoagulants. and edoxaban and rivaroxaban can also be recommended after in case of low molecular weight heparins. The next case scenario, patient BG is a 68-year-old male patient, and she has a symptom of limited exertion and out of bed only to bathroom for three days. History include ischemic heart disease, hypertension, DM, and he had a history of pulmonary embolism 2 years ago. He is a smoker, and the medication include bisoprolol, lisinopril, ranelagin, furosemide, spironolactone, and metformin. And his lab value normal except BNP. So, which is the appropriate venous thromboembolism prevention for this BG? The options are fondaparinux, apixaban, enoxaparin, and there is no prophylaxis is recommended for this patient. The correct answer is enoxaparin 40 mg once daily. So the patient is in a VT risk. How we can identify? These are the population who are at increased risk of thromboembolism. The major risk is for the orthopedic surgery. It's around 57 to 84%, and then for trauma, patient with spinal cord injury, then critical care patient 10 to 20, and medically ill patients. The current condition patient is 10 to 20. So in case of surgical patients, there is a risk score is the Caprini score. Caprini score is ranging from 1 to 5 for each factors. So based on the patient condition, we can able to provide the anticoagulation therapy. These are the recommended anticoagulation agents for the post-operative surgery in orthopedics. All the parenteral agents as well as newer oral anticoagulants is recommended for the knee replacement surgery, hip replacement surgery, and fracture. And in case of surgery, because of the bleeding, is recommended to for the mechanical prophylaxis rather than the oral or parenteral anticoagulation therapy. And in case of other surgeries, the parenteral agents are only mainly recommended in majority of the cases. Unfractionated heparin, enoxaparin, dalteparin, and fondaparin. In majority of the hospital, enoxaparin 40 mg once daily regimen is used as an anticoagulant therapy. Then in case of non-surgical cases, there is a risk assessment score is called PERDOA. Okay. This score is also, the factors include anti-cancer, previous VT, reduced mobility, etc. And based on this risk score also, we can able to assess the coagulation risk of the patient. And if the patient score is less than 4, there is no prophylaxis recommended. And in case of score is more than 4, low molecular weight heparin and additional mechanical prophylaxis also recommended. And the usually recommended dosings are enoxaparin 40 mg, fondaparin 2.5 mg, and rivaroxaban. Oral option is only for rivaroxaban 10 mg once daily. And in case of critical ill patients, unfractionated heparin, low molecular weight heparin, and fondaparin have less sufficient data. So always low dose unfractionated heparin and low molecular weight heparin is recommended. Here also, based on the patient body weight, enoxaparin is using 40 mg once daily. So how long this VTE prophylaxis is recommended for these patients? For the surgical patients, when will be this thrombotic risk relieved? Until till that time, we can continue the anticoagulation therapy. In the orthopedic surgery, up to 3 weeks can be able to recommend. And in case of generally medical ill patients, up to 39 or 40 days, we can able to recommend the VTE prophylaxis. The next case scenario, due to the time constraint, I am not discussing the more details. This patient is a patient with a bioprosthetic valve. For this patient, which is the recommended anticoagulation therapy here? Aspirin, warfarin, apixaban, and dabigatran. The option is warfarin 7.5 mg with an INR of 2 to 3. So, if a patient have undergone any valvular surgery, anticoagulation is definitely required. There are two types of valves are there, mechanical valves as well as bioprosthetic valves. For these valve replacement patients, direct oral anticoagulants are not recommended. So mitral valve replacement, tricuspid valve replacement, aortic valve replacement, and TAVI, that is transaortic valve implantation. For all three conditions, anticoagulation is mandatory, and for mechanical heart valve, lifelong requirement of anticoagulation is there with vitamin K dependent oral anticoagulants. And in case of bioprosthetic heart valves, the recommended duration is 3 months. And if there is another compelling factor for anticoagulation, the medication needs to be continued for lifelong. So, in all patients with vitamin K dependent oral anticoagulants, an INR target is advised for the patient. INR target is 2 to 3 for the majority of the condition, except certain conditions such as mechanical heart valves. It ranges from 2.5 to 3.5 and up to 3.5 to 4.5 in certain valve patients. So, doctor always advised to follow this target TTA and PTNR. Then what are the options for vitamin K anticoagulants? Usually warfarin as well as azenocarbainol is there in the market, and there is no head-to-head comparison between this warfarin and azenocarbainol. Regarding the onset of action, warfarin take around 2 to 3 days for the onset of action, and in case of azenocarbainol, within 48 hours it will act. And in case of duration of action, it will take around 5 days to complete action for warfarin, and in case of azenocarbainol, it will take around 48 hours. The azenocarbainol is more fast acting. The mechanism of action of these vitamin K oral anticoagulants include it will inhibit the production of these factors 2, 7, 9, and 10. The first graph showing the 0th day we are starting the agents. At that time, the coagulation factors are at the peak level, 100%. So there is no action for warfarin as well as azenocarbainol for the already existing anti-clotting factors. So it will take around 0 to 7 days for the complete elimination of these coagulation factors. At that time, the patient is at high risk. So in this condition, a bridging with a parallel anticoagulant is recommended when we are starting and vitamin K dependent oral anticoagulants. The next picture showing simplified nomogram for warfarin maintenance. The warfarin dose is adjusted by checking the PTNR. We have to get a baseline value, then repeat the dose in the initial days very frequently, 1 day or 2 days, and we can reduce the frequency based on the INR level of the patients until we get the target, and after that we can reduce the frequency for maintaining the anticoagulation level. Then drug interaction of vitamin K oral anticoagulant. Even if any drug interaction happens, we are always checking the PTNR. We are always after the basing the PTNR only we are adjusting the dose. Even the patient, if patient have a drug interaction with high dose changing, we can reduce the initial dose of the patient. Otherwise, we can only able to. Otherwise, we are going with the same dose by checking the PTNR level. Here also, along with the drug interaction, drug food interaction is also there. The foods with the vitamin K rich diets actually decrease the action of PTNR. So in case of warfarin administration, the doctors as well as clinical pharmacists always advise the patient to reduce the vitamin K diet. Then time in therapeutic range. The time in therapeutic range is for the evaluation of anticoagulation. There is a days range as well as percentage range is there. When we check the PTNR at the day 1 of a month, and again we are checking the day 31st of a month, and within that period, how much period the patient is in the therapeutic level. Based on that, we can modify the therapy in order to get the patient is in the therapeutic range. Then the same case scenario of the bioprosthetic valve. Here is the question is, the doctor want to change the vitamin K oral anticoagulants to the direct oral anticoagulants. So whether this option can be possible or not. Actually, The direct oral anticoagulants can be directly changed to other vitamin K dependent oral anticoagulants. I will explain in the following slides. So here we are dealing with the switching of parenteral anticoagulants. If the patient have any heparin infusion, we can change it to low molecular weight heparin, and it could be started within 1 to 2 hours of infusion. And from LMWX to another LMWX, in the next scheduled dose, we have to initiate the drug. And in case of LMWH2 injection bolus, we can start the injection bolus after the next scheduled dose within 1 to 2 hours. And in case of switching parenteral to vitamin K dependent oral anticoagulants, we can continue the same regimen and check the INR. Start the anticoagulant first, vitamin K anticoagulant first, and when the INR is more than or equal to 2 for at least 24 hours, we can remove the parenteral anticoagulation and continue the vitamin K dependent oral anticoagulation. Then switching from anticoagulants to DOACs, when we are, then the first image showing VKA to NOAC. When we are changing from vitamin K oral anticoagulants to DOACs, we can check the PTNR level, and once the INR, we can stop the warfarin therapy, and once the INR level is less than 2.5, we can initiate the direct oral anticoagulants. And the vice versa, when we are changing from NOAC to vitamin K oral anticoagulants, we can start the anticoagulant with newer oral anticoagulants, and once the INR is less than 2, we can remove this NOAC and go ahead for the anticoagulation therapy. And in case of unfractionated heparin, we can start with the next scheduled dose of vitamin K, next scheduled dose of unfractionated heparin to the NOAC, and vice versa also. Next, we are dealing with the perioperative management of direct oral anticoagulants. The direct oral anticoagulants can be discontinued 24 to 48 hours based on the bleeding risk of the patient. Similarly, we can restart after 12 hours or 24 to 48 hours after the surgery based on the bleeding risk of the patient. This is the renal condition. Based on the renal condition also, we can recommend it to dose modify. Then this is the case scenario with patient is on bleed. One of the patient have administered the warfarin, and patient have an INR of 10.4. And what will be the your choice of answer? Hold warfarin or warfarin administered with 4 PCC, and warfarin with vitamin K, and warfarin vitamin K 10 mg intravenously. The answer will be vitamin K 5 mg, because if the patient have no bleeding, we can able to discontinuation of the warfarin is also only recommended. And if the patient having INR value more than 10, we can discontinue, and oral of vitamin K can be given. And if the patient is in bleeding, we can able to give the antidote of warfarin vitamin K and factor 4 PCC complex concentrate in order to reverse the effect. And in case of newer oral anticoagulants, we can able to administer factor 10A inhibitor or factor 2A inhibitor reversal agents. The idarucizumab is the agent for factor 2A inhibitor, that is for dabigatran, and for the factor 10A, the reversal agent is andexanet alpha. Currently, these agents are not available to us, and this idarucizumab is available in our market. Then reversal of parenteral agents can be done by partially dialysis, and their antidote is protamine sulfate. I am not discussing the unit dose or the dosing schedules here. Then finally, a case of a woman who having prosthetic valve replacement in the last year, and the patient is planning for pregnancy. What will be the doctor's advice regarding this condition? In the pregnancy and postpartum consideration, the unfractionated heparin as well as low molecular heparin is recommended in the both population, but the fondaparinux have lesser data. But in case of vitamin K dependent oral anticoagulant, postpartum recommended to administer, but in pregnancy not usually administered. And in case of DOACs, it's not at all administered in pregnancy as well as postpartum. In the anticoagulation in pregnancy, the doctors are recommending to reduce the dose to less than 5 mg in the first trimester, and or you can continue the low molecular weight heparin. And finally, when we are moving to the third trimester, we can continue with low molecular weight heparin, and finally changing to unfractionated heparin or low molecular weight heparin in order to reduce the bleeding complication. So these are the main topics we are covered here. I am recollecting the points once again. We are discussing the atrial fibrillation, treatment and prophylaxis, deep vein thrombosis, pulmonary embolism, treatment and prophylaxis, then prosthetic valve replacement, anticoagulation therapy, and finally switching, and thereafter pregnancy consideration of anticoagulants. The take-home points include the indication of the anticoagulation we must know, that is risk factors we have to identify for every patient, and know the thrombotic risk factors and method for assessment for every patient categories. Then selection and duration of anticoagulation requirement, treatment options for available each conditions. Then we have to monitor the pharmacokinetic, pharmacodynamic, check and check food interactions. Then available monitoring parameters and adverse effects of the possible adverse effects of the medications, and what are the available reversal options for these agents in case of emergency. So I think I have covered majority of the antithrombotic conditions and their management. And in this Women's Day, I am emphasizing the anticoagulation therapy, especially for women, since they have more than risk in men population in the atrial fibrillation. And in case of hormonal therapy, when they are taking hormonal therapy, they are again at high risk of developing thrombosis. And again, in the case of pregnancy, they have to face the administration of injectable anticoagulants for a long period, or otherwise they have to take the vitamin K dependent oral anticoagulants at a moderate risk of developing fetal problems. I think I have covered that topic, and I think everyone understand the requirement as well as monitoring parameters, everything regarding the anticoagulation therapy. And I am moving to the discussion section. Rajesh sir, we can go ahead with any questions available for any delegates.
Thank you so much, Dr. Vigas, for this excellent presentation, especially that was rich in real clinical cases. And I'll not be so happy today because you mentioned that, we are adding additional points in chat score for the females, especially today is in the International Women's Day. Why do they have additional risk factors now?
Because of the in that female sex category is recommended as a Chatsu score system, since the hormonal variation. Because of the hormonal variation, they are more prone to the development of clot formation. Similarly, in the pregnancy condition also, and if the patients are on hormonal therapy, they are again, these hormonal agents are also prone to development of clot formation.
Thank you. Do we have any questions from the audience? I don't see anything in the chat room.
Good evening, sir. Dr. Vikas, thank you for that excellent presentation. I just have a small question to ask you. Can you recommend which is the best score to assess dual anticoagulation therapy in patients?
Dual anticoagulation therapy.
Yeah.
Actually, dual anticoagulation therapy is not recommended in majority of the conditions, except in case of when we are switching. Means, as I mentioned earlier, when we are starting an vitamin K dependent oral anticoagulant such as warfarin or azenocarmarol, we have to bridge the therapy with injectable agent such as either unfractionated heparin or enoxaparin, okay, until the INR become more than equal to at least for 24 hours. So no other agents are not recommended to combine. That is, NOACs is not should be combined with vitamin K. You got my point?
Yeah, but there are certain prescriptions, I think, where and I have seen dual anticoagulation therapy. So that's what I just asked.
In my experience, dual anticoagulant therapy is not recommended, but dual antiplatelet therapy as well as antiplatelet therapy with anticoagulant therapy is available.
Yeah, so any possibility to assess the risk for antiplatelet and anticoagulation therapy? I mean, to assess whether the patient is agent for this dual therapy, antiplatelet and anticoagulation.
Okay, yeah, I got it. Yeah. In case of percutaneous coronary intervention such as angiogram as well as angioplasty, the doctors are recommended to start dual antiplatelet therapy, either aspirin with clopidogrel and ticagrelor with aspirin. Okay. In this case, there is an option is therefore in this there is a checklist for coagulation risk factor assessment is there, and in that condition also, if the patients have any concomitant disease such as atrial fibrillation and they are undergone any this angiogram or angioplasty, these agents can be prescribed. So there is a checklist is there, but I exactly don't remember the name of that tool, and I will convey the same to you later. Okay.
Yeah, thank you.
Do we have any more questions from the audience?
Just a question. Hello.
Sir.
Please, sir.
See, many of the government insured patients, like CASP, they have only warfarin in their drug list, being the cheapest one.
Okay.
So, do you think there is a disadvantage of just giving warfarin alone in most of these cases? But it is not recommended also, like, in many of the cases.
Before entering into the era of direct oral anticoagulants, vitamin K dependent oral anticoagulants are only the drug of choice in case of thromboembolic disorders. But after entering these direct oral anticoagulants, the majority of the guidelines are recommended to initiate these direct oral anticoagulants instead of warfarin or azenocomarol in certain conditions, because they are equally effective, as well as there is no strict monitoring is not available for the direct oral anticoagulants. That like a frequent PTNR is no need to monitor, and diet adjustment is not recommended for these direct oral anticoagulants. So when considering these direct oral anticoagulants also should get approval from the insurance agencies in order to add their guidelines. I think we can recommend this with the available guidelines into that insurance companies for adding this also into their guidelines also.
Thank you, sir. Thank you for the question. Reversal of warfarin, somebody comes to the emergency room with an elevated INR. How do we manage these patients usually in an emergency situation?
In case if the patient came with a mild bleed, such as any patient fall and the patient is taking warfarin medication and she had a cut in her forehead, then at that time we can able to administer vitamin K injection, and it ranges from 5 to 10 mg intravenously. It's around 10 mg preparation can be administered over 30 minutes. This can reverse the effect of warfarin, and the agent can be administered up to 3 days, and beyond that we can able to administer, but the guidelines is recommended to limit the duration to 3 days, because the vitamin K administration, it will increase the chance of warfarin resistance. So when we are reinitiating the warfarin, we can be able to get the INR with the fast manner. We have to wait for a long time period, and if the bleeding cannot be controlled with vitamin K administration. The complex, that is 4-PCC, means these 4 factors, that 2, 5, 7, 9, 4-factor complex concentrate can be administered for these patients. Its dose is ranging from 25 to 50 units per kg can be administered, as well as you can also administer fresh frozen plasma FFP for the reversal of the warfarin effects.
Okay, you remind me something about, like, when you mentioned about the warfarin resistance. Can we apply this, the principles of pharmacogenomics in anticoagulation?
Yeah, exactly. The CPIC is one of the American society. They are dealing with this pharmacogenomics. Actually, they are introduced a algorithm for the vitamin K agents administration. Based on this algorithm, we have around 2 to 3 alleles such as VKORC1 and CYP2C9, and one more allele is available for the metabolism as well as absorption of vitamin K dependent oral anticoagulants. Even we can consider these factors. In my personal experience, our dosage adjustment is always depend on the INR level. So we can able to check the PTNR level very easily, but we can able to find out this pharmacogenomics variation by monitoring individual patients. But when we considering a whole group patients, such as when comparing with the African population to the Indian population, the African population have high levels of this VK or CA1 and CYP2C9 alleles. So they are easily metabolize these drugs faster. So we have to give a initial high dose to this African population, and compared to that, we can only give a moderate or low dose to the Indian or Asian population when we are correlating this pharmacogenomics into this vitamin K anticoagulant administration.
Someone could be going for an elective surgery who is already on anticoagulation with the warfarin. So what will be our advice as a clinical pharmacist for such patients?
So we have to consider both the thrombotic risk as well as bleeding risk when they are going for the surgeries. When the patient is going for a dental procedure or cataract procedures, the bleeding risk is very less. So in that time, we can able to advise the patient to continue the therapy. But in case of major surgeries, it is highly recommended to discontinue the vitamin K dependent oral anticoagulants. Initially, at the time, we have to check the INR of the patient, and if the INR is more than or equal to 2, we have to discontinue the warfarin, and we have to initiate a parenteral agent. Then we can repeat the PTNR level in the next following days, and when the INR become 1.5 or less than that, and at the INR level that can be acceptable by the surgeon, we can able to go for the surgery, and we can reinitiate the agent after 6 hours of surgery or later based on the patient bleeding risk.
Sure. And what if there is an emergency? Somebody is already on anticoagulation who want to do it. You want to go for an emergency, procedure.
In this case, as we mentioned earlier, we can able to give a fresh frozen plasma or this prothrombin complex concentrate. We can able to reverse this action within around 4 to 6 hours.
Okay.
Otherwise, we have to go with the bleeding risk. We have to take up the patient for the surgery, and we have to face the complication of the warfarin related bleeding.
So if you look at the most of the international guidelines on anticoagulation, most of these guidelines, they don't recommend to use direct oral anticoagulants, especially for the valve replacements. So what's your comment about this?
As per the guidelines, these direct oral anticoagulants are not recommended in this case condition, especially in case of valvular heart diseases and in pregnancy population. In the pregnancy populations, they are not even studied these drugs. But in case of valvular heart disease, these drugs are studied in South Korea and US and AHA and the European Society also. They have conducted several studies by comparing these four DOACs such as apixaban, rivaroxaban, dabigatran, edoxaban, and they have to withdrawn these studies because of the increased bleeding rate. Because of this much of adverse effects found to the population by initiating these agents to the valve replacement patients or valve heart disease patients, they are forced to withdraw these studies. That's why these medications are not came into the guideline till now.
Okay. What other thing came to my mind was like, in our usual practice, and especially in post-operative orthopedic cases, most of the surgeons, they prefer to use aspirin like 150 milligram dose. And I've seen one of your slide mentioning about the parenteral agents, DOACs, etc. So kind of like conflicting things from actual clinical practice versus the guidelines.
Since I was working in the orthopedic departments in late 2018, I also found that they are start with the ecospirin 150 mg. They are initially give a parallel agents in the first in the second day of the surgery, and after that they change the therapy to 150 mg once daily. Initially 7 days in the hospital, and we continued up to more than 3 weeks. Total of 4 weeks. This will be continued. As per the guidelines of American Society of Orthopedics, they also recommended to initiate as parallel therapy or direct oral anticoagulants such as dabigatran 220 mg or rivaroxaban 15 mg. That's their advice. But there is a parallel study conducted by the American Heart Association as well as American Society of Orthopedic Surgery. In a small population, they have found that this ecospirin is non-inferior to the effects of direct oral anticoagulants or the parallel therapy. That's why they are advising this aspirin 150 mg therapy to the patients. They are undergone total hip replacement or total knee replacement.
Okay, so again, rivaroxaban 2.5 milligram, it's available in the market, but we don't see that as a recommendation in your presentation today.
Even if the rivaroxaban is a anticoagulant agents, the dose recommendations only too low. That's 2.5 mg. It's only recommended in case of any additional thrombotic risk, those who are undergone a percutaneous coronary intervention or the patient have any coronary artery disease. The patient is not willing to go for any surgery, or the patient is not go for the patient is not subjected to any percutaneous coronary intervention or surgery. They can able to prescribe antiplatelets such as aspirin or clopidogrel. Along with it, we can start rivaroxaban 2.5 mg twice daily.
Thank you. We got a lot of students in our discussion today, and academicians and the practicing pharmacists. So they'll be much interested. How does the pharmacist or the clinical pharmacist led anticoagulation clinic works in some of the hospitals? I've seen as a common practice outside India. Most of the hospitals, they have a pharmacist led, clinical pharmacist led anticoagulation clinics. So how does this work?
Okay. In the majority of the hospital, the clinical pharmacists are work as a part of anticoagulation clinic. In the anticoagulation clinic consists of clinician, nurses, and pharmacists and the patient. And other documentation work doing staffs also available. So in an anticoagulation clinic, they are mainly start from the inpatient setting. When the patient is admitted any thrombotic conditions, the physician start anticoagulant. The clinical pharmacists educate the patient regarding the indication, drug, dosage adjustment, monitoring parameters, adverse effects, everything, as well as dietary modifications in case of vitamin oral anticoagulants, and what is their modification they are expecting from them. At the time of discharge, the clinical pharmacist educate the patient properly and advise them to contact the clinical pharmacist or the responsible person in order to inform the INR level for medication management. Based on that INR level, the clinical pharmacist adjusts the dose, as well as if the patient have any outside consultation or they are starting any OTC or they are moving for any Ayurvedic preparation, all the problems can be communicated with this clinical pharmacist and they can adjust their medication management. In crucial situations, the clinical pharmacist can also consult with the consultant cardiologist or cardiovascular surgeon for any expert opinion from them. This will be acting as a hospital activity, as well as in the outside hospital also, the patient can able to contact with the clinical pharmacist for better drug therapy monitoring. This way, the anticoagulation clinic works.
Thank you. And for those who are attending, it's now we can do the INR at the bedside with a small, very small device, which is very similar to the, the blood sugar monitoring. It's like a point of care testing machine. It's available now. So the process is very simple now. Do we have any more questions from the audience?
Sir, I have a small question.
Please.
Dr. Vikas, do you remember any case where you have had any particular case where ADR, you have documented any ADR with NOAC? And
So
which
20
NOAC
years,
was
of course.
it? Yeah, which NOAC was it?
Dabigatran.
Yeah, dabigatran, and the case was?
Yeah, dabigatran is very highly gastric irritant agent. So when we are prescribing dabigatran, always recommended to administer a proton pump inhibitor before that. So one of the patient, when given with the dabigatran, patient had a GI bleed. Hello,
Okay,
madam, can you hear me?
Thank you.
Yeah,
Thank you.
Yeah. Okay.
So once again, thank you so much, Dr. Vikas, for this wonderful presentation. Very informative, with a lot of active clinical cases and with a lot of information for the students and the practicing pharmacists. Thank you. Over to Dr. Sonu Binni.
Thank you. Thank you
Dr.
so much.
Sinu. Okay.
I think Dr. Sinu can conclude it, right?
Yes, sir. So, as we conclude the session on clot management and prevention, I want to extend my sincere thanks to our moderator, speaker, and all of you, all the audience, for your active participation and insightful contributions. Together, we can ensure that patients receive the best possible care and that future generations benefit from our collective efforts. Once again, thank you all for your participation. Over to Sonu.
Thank you, ma'am. It was an informative session, and as a token of gratitude and appreciation, on behalf of KPGA, we'd like to present a certificate to our speaker. Thank you so much, Vikas sir, for your valuable time and your wonderful session. And also, we would like to present a certificate to our moderator, to the chair of the session, Dr. Sinu Thomas. Thank you so much, ma'am. And special thanks to the master brain behind this event, Raj sir, on behalf of KPGA. Thank you so much, sir. Once again, we are thanking all of you for your wonderful participation and cooperation throughout the session. And to set an official note of gratitude, I would like to invite Dr. David Paul, one of the very active member of our forum, for the vote of thanks. He's working as the assistant professor at Naipur, Kolkata. Welcome, sir.
Thank you, Sonu Beni. Is it audible from my side?
Yes, sir. Yes, sir. You're audible.
So, respected President Dr. P.K. Srikumar sir, Mr. Abdul Nasser sir, our secretary. Today's scientific session resource person, Dr. Vigas PV, moderator and mastermind behind today's session, Rajesh Talaparman sir. Today's chair, Dr. Sinu Thomas madam, Dr. Ansa Philip ma'am, Dr. Nishit sir, principals of various pharmacy colleges, faculty members, working pharmacists, industrialists, Ms. Sonu Bevni, Adira madam, and dear budding pharmacists, and also KPGA executive committee members, and women's forum members, and students forum members, and all those who are gathered here online for this national webinar on clot management and prevention, journey through anticoagulants. A warm good evening to one and all. And first of all, Women's Day wishes and Shivratri wishes and prayers. It's my privilege to propose a vote of thanks on this auspicious occasion. First of all, I'd like to extend my sincere thanks to God Almighty. I'd like to extend my heartfelt thanks to our President, Dr. P.K. Srikumar, who is a source of guiding light and motivation for all of us in successfully organizing events and also for delivering today's presidential address. Thank you, Srikumar sir.
Thank you. Thank you.
I must mention a deep sense of appreciation to our dynamic secretary, Dr. Abdul Nasir sir, for his support, guidance, and also for delivering today's welcome note. Nasir sir, thank you, sir. Next, I would like to extend our deepest gratitude, Dr. Vigas PV, Assistant Manager, Clinical Pharmacy Services, Mitra Hospital, Calicut, for sparing his valuable time with us in his busy schedule, and also for giving in-depth inputs into the topic clot management and its prevention, especially touching the areas of drug interaction and anticoagulant drug interaction importance in the anticoagulant area. Today's talk was very informative and insightful. Thank you, sir. On behalf of KPGA, I'm very much thankful to you, sir. I must remark a profound sense of gratefulness to Mr. Rajesh Talpamba, sir, for moderating this event and being a crucial part in this event, and also to Dr. Sinu Thomas, madam, for chairing today's webinar. Thank you, Rajesh, sir, and Sinu, madam. I am profoundly thankful to Ansa Philip, madam, and Dr. Nishit, sir, for sharing their valuable inputs. Thank you, Ansa, madam, and Nishit, sir. On behalf of KPGA, I extend my gratitude to all the principal, industrial personalities, faculty members, hospital pharmacists, clinical pharmacists, executive committee members, and women's forum members, student forum members, and today's upcoming budding pharmacists for participating in this session. Thank you all. A special thanks to Mrs. Sonu Beni, our anchor and master of ceremony of today's event, and also for Adira madam for her melodious prayer song. Thank you, Sonu Beni and Adira madam. I'd like to express my sincere thanks to all the organizing committee members from the part of KPGA for their valuable input for the success of this event. And finally, on behalf of KPGA and myself, Dr. David Paul, thanking you one and all for making this event a grand success. Thank you.
Thank you, sir.
Thank you.
Thank you so much, sir.
So thank you all.
Sonu, mate certificate is per
Yes, yes, sir.
E-certificate.
Dear participants,
E-certificate.
we are sharing the certificate link for getting your e-certificates in the chat box very soon. And this link will be active for only 15 minutes. So we are kindly requesting all of you to utilize the chance. So once again, on behalf of KPGA, we are wishing you a very wonderful Women's Day and be an inspiration to everyone. And now, let's move to the national anthem. We are kindly requesting all of you to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Sorry for the technical error and thank you once again. Good night.
Okay, thank you for all and good night.
Good night,
Thank you.
everyone.
Good night.
Good night, sir.
Okay.
Thank you, sir. Good night.
Thank you,
Good
sir.
night.
Good night.
Good night. Good
Good
night.
night, everyone. Thank you so much.
Yeah. Good
Good
night.
night, everybody.
Thank you.